good afternoon. All right, welcome once again to today's edition of internal medicine. Today we'll be looking at hypoglycemia. The last time we spoke about diabetes mellitus. So today we're looking at hypoglycemia. Okay. All right. So when we say hypoglycemia, from the word hypo, meaning that is what? Reduce. Glycemia meaning glucose. Okay. So this is reduced and we have glucose. Okay. So when the glucose level in the blood or in the serum is reduced to a certain level, then we'll say that it reduced beyond a certain threshold, then we'll say that it is hypoglycemia. But you should know that that threshold varies from country to country, from one jurisdiction to the other. Okay? Some people will say that the threshold should be 2.8 to 3.3 millimoles, okay, per liter. Okay? But if you add 2.8 to 3.3, it should give you what? 6.1. And if you divide 6.1 by 2 to have an average, you should have 3.05. So if you should approximate this, we should have around what? 3. So we'll take the threshold to be what? 3. Okay? So when we say hypoglycemia, we can define it as what? Plasma glucose or serum glucose. Plasma glucose. Plasma glucose less than or equal to what? 3 millimoles per liter. So if we have this, then we can say it is equivalent to hypoglycemia. Okay? We are talking about hypoglycemia in adults. Are you following? Okay. So if we have plasma glucose less than or equal to 3 millimoles per liter, we will term that as what? Hypoglycemia. Is that clear? Okay. Now, then we should be asking ourselves, okay, in the plasma, what will be the normal black plasma glucose level? Clifford?
3.5 to 5.5 millimoles per liter.
Yes, you are right. 3.5 to 5.5 millimoles per liters. Meaning that from 3 to 3.5, there is that boundary where we expect recovery. Either we advise the patient to take in food, okay, or the body would put in measures. For example, like the release of counter-regulatory hormones, as we know, the cortisol, the epinephrine, the growth hormone, the glucagon, and also the last one. We mentioned that already, epinephrine. So cortisol, growth hormone, glucagon, epinephrine. That's correct. All right. So in adults, we'll take this as the threshold for hypoglycemia. What of in children? In children, the threshold will be a bit lower. So in children, we'll take it 2.6 millimoles per liter. But bear in mind, these values can change from one jurisdiction to the other. Is that clear? Is that clear to us? All right. Now, the next thing we want to talk about is the causes of hypoglycemia. Causes of hypoglycemia. So for the causes, we are going to divide them into two, okay? So the first instance, we will divide them into two categories, okay? So in the first instance, we will say that in diabetic patients, what are we thinking about? We will say that they are on medications. Which medications? So it means that they will be on insulin, right? Or sulfonylureas. And if we remember very well, sulfonylureas, by mechanism in relation to insulin, they are what? Insulin secretagogues. And we said, by mechanism, the sulfonylureas, their receptors belong to what? ATP dependent what? Potassium channel what? Inhibitors. So it means that when you have sulfonylurea binding to these receptors localized on the potassium channel, it will inhibit the potassium channels, reducing the membrane potential, causing an influx of calcium into the beta cells of the islet of Langerhans, right? Then as a result, there is going to be what? A release of insulin. So in that case, we will see that the sulfonylureas can be considered as what? An insulin secretagogue. Are we getting that? So if you are producing insulin more than necessary, then the glucose level will what? Decrease. Because we know insulin clears the glucose. In what way? By enhancing the uptake of what? Glucose by the cells, and by also converting the glucose into what? Glycogen. In the process we call glycogenesis, which we spoke about the last time, that the structure will be glucose. From glucose you are going to where? Glucose 6-phosphate. From glucose 6-phosphate, where do you go? Glucose 1-phosphate. Then from there you go to where? The uridine diphosphate what? Glucose. From uridine diphosphate glucose, where do you go? You come to what? The 1-4 glucosyl or glycosyl units, or 1-4 glycosyl what? Residues. Then from there, you are going to have the branching enzyme coming in and converting these residues into what? Glycogen. Please, do you understand? All right. So insulin, so it means that in this case, the diabetic patient is going to be on what? Insulin or sulfonylureas, which will give them what? The hypoglycemia. Then you ask yourself, in what scenario? In what scenario? So in that case, if they have mixed a diet, in cases of what? A mixed diet. If they have increased their physical activity, okay, increased physical activity, because in that case, there will be what? The glucose will be utilized in what? Excess. The glucose will be utilized rapidly because you need ATP you need glucose for the generation of ATP when they go into the Krebs cycle. Are we getting that? Or when they enter into the process of glycolysis, okay? All right, so mixed diet, increased physical activity, then also in a case of accidental or non-accidental overdose, true or false? Yes, all right. So if there's an overdose, can you see glucose levels will be reduced rapidly? Then at the end of the day, what are you going to have? Hypoglycemia. Is that clear? So in diabetic patients, when they are on these drugs and these scenarios happen, they can go into what? Hypoglycemic state. Is that clear? Now, let's take the non-diabetic patient. For the non-diabetic patient, then always, non-diabetic patients always explain the mechanism. So explain the mechanism is simply to tell you that to get the causes, then use explain as an acronym where all the causes would be gotten from what? Each of the letters. Are we getting that? So in this case, in non-diabetic patient, always explain. Now let's talk about the explain. So the causes of hypoglycemia in non-diabetic patients, make sure to what? Explain. Are we getting that? Yes. So now let's look at the causes now. The causes here. In that case, the causes here. So the first one, we say explain. So we are going to have X. Okay? So we can make this X smaller. X. Drugs. So for the exogenous drugs, we can think of, so we will be asking ourselves, which drugs can predispose a patient on them to what? Hypoglycemia. So we can remember by using an acronym, we'll say that CBA. So CBA, okay, CBA. So in that case, we can think of sulfonylureas. We can think of insulin. We know why. We said that. We can also think of insulin growth factors. Insulin growth factors. We can also think of beta blockers. True or false? Yes. Remember when we were talking about hypertension? We said categorically that if a patient is put on beta blocker and also thiazide, they what? Increase the risk of a new onset diabetes in such a patient, right? But the beta blocker again, if used, can predispose the patient to what? Hypoglycemia. And another thing that you should know is for beta blocker, assuming you go for an exam and they ask you, why is it not advisable to put a diabetic patient on insulin on a beta blocker? And if you are going to do so, you should advise the patient on the side effect of insulin, which will be hypoglycemia. Why? Anna, go ahead.
One of the core functions of the liver is not due to glycogen synthesis occurs in the liver.
Yes.
So once liver function is impaired, enzymes required for the synthesis of glycogen also are impaired.
Yes.
So we have reduced synthesis of glycogen.
And in addition, the reduced synthesis of glycogen, it means that you are using just one pathway. Yes, and that would, kind of deplete the stores of what? Glucose in the form of glycogen. Yes, we are going to say something like that. Is true.
The liver is the main center of glucose.
Excellent, that's the key word. And also,
Glycogen.
you go for further studies. Honestly, this candidate should be passed quickly. You sign your paper so that you go for School of Further Studies. Excellent. Today you have been exhibiting a quantum jump from N1 to N4. Your excitation energy is what? In abundance, in an avalanche. That is good. All right. So that is correct. The next one. A. Addison's disease. Addison's disease. Addison's disease, James, is also known as no, Rebecca. Excellent. Hypocortisolism. Remember I told you Addisonian disease is more like the opposite of what? Cushing's syndrome, where you have hypercortisolism. Are we getting that? Are we following? Okay. Now, how does Addison cause? Addison disease, how does it cause? It's very clear. Yes, go ahead.
There's a decreased amount of cortisol. Thereby,
Due to what?
due to
The dysfunction? Dysfunction where?
dysfunction in the adrenal gland,
Specifically where?
specifically the zona fasciculata.
Excellent.
So, because of the decreased amount of cortisol, insulin levels may it's supposed to counter-regulate insulin levels. So, insulin levels may be high, causing hypoglycemia, and also cortisol is also needed for glucose.
Excellent. You are right. Excellent. You are right. Today, you guys are, you are excited. I don't know, it's because of That's good. It's good. It's good. I'm enjoying the scenario. All right. So that's for Addison disease. The next one is islet cell tumors. An example of an islet cell tumor will be is what? Insulinoma. Then the question is, how would insulinoma predispose? Aban, how would insulinoma predispose or cause hypoglycemia?
Yeah, so we know that insulin is produced by the beta cells in the pancreas. So when you have tumor in the insulinoma, you won't be able to express or produce more.
It will not be able to.
It's going to block the production or the release of the insulin.
Go ahead.
So we know that tumors cause hyperproliferation.
Excellent.
So the tumor is going to cause more insulin to be produced. And the insulin will now cause hypoglycemia.
Yes, the insulin will now clear the bloodstream of what? Glucose, leading to what? Hypoglycemia. So insulinoma means that excess production of what? Insulin. Anytime. That's why we said that overdose of insulin here, accidental or non-accidental overdose of insulin, would give us what? Hypoglycemia in what? Diabetic patients. Remember. All right. Or immune hypoglycemia. When we say immune hypoglycemia, what comes into mind? Anyone? Immune hypoglycemia. Anyone? Do you know what it means? Remember when we were talking about, yes, go ahead. In which way? When we go that way, then we should be having hyperglycemia. Yes, go ahead.
Anti-insulin receptor antibodies.
Excellent. You are right. Anti-insulin receptor antibodies. Anti-insulin receptor antibodies. You are right. So in this case, how would that, predispose? As is.
Okay, so the anti-insulin receptor antibodies, they would attack the beta cell that would cause reflex release of insulin, which would predispose the person to driving all the excess glucose in the blood into the cells.
Well, you are right. So in that case, it means that when that happens, it's more like an inflammatory reaction that would release, that would cause. So this is what is going to happen. You can take it at the molecular level too. That if you are having those antibodies coming to attack the receptors, what will happen is that you are going to have more of an antigen antibody complex, and that would activate the inflammatory cascade. And in that case, the membranes will become what? Hyperpermeable. In such a way, we are going to have membrane potential reducing, calcium influx. Are you getting that? Into the beta cells, and what? There will be secretion of insulin in what? Adequate amount or excess amount. That would kind of decrease the glucose level. That's why you are saying that at the end of the day, glucose levels will decrease because the insulin will be produced in excess. Then the next one, let's move on. Yes, please. Yes. No, it's only for non-diabetic patients. Thank you very well. If you have an obese, somebody who is obese, one of the side effects of sulfonylurea we said is weight gain. All right, weight gain. Okay, we said weight gain, right? So it means that if you want to build your muscles, are you getting that? If you want to build, some of the, those who, bodybuilders, some of them, they use insulin and what? They can also use sulfonylureas, especially the insulin growth factors or the sulfonylureas to kind of help them build their body. So in that case, yes, sulfonylureas can be used in that scenario. Okay. All right. Yes. So all the way to the pancreas, or even so, no, all the way to the pancreas means that wherever, even in the liver, wherever you are going to have the receptors, so it can work in two ways, where there will be these antibodies, whenever they react or whenever they bind to the receptors, they are going to have a stimulatory effect. Okay, or in another way, we can take it in this way, that once you have the antibodies binding to the receptors, they would mimic an insulin-like reaction. Are we getting that? Opening the pores or opening the channels for glucose to enter into the cells. Are you getting that? So once glucose is entering into the cell, what happens to the level in circulation? It will reduce. Are we getting that? So the next one is going to be non-pancreatic neoplasms. Non-pancreatic neoplasms. So under the non-pancreatic neoplasms, we can think of what we call fibrosarcoma. 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 And we can also think of hemangiopericitomas. Okay? Hemangiopericitomas. So if you are thinking about the causes of hypoglycemia in non-diabetic patients, always remember to explain the mechanism. Where they explain becomes the acronym for the causes. Exogenous drugs, pituitary insufficiency, liver failure, and other rare enzyme defects. Addison disease, which is also known as hypocortisolism. Then we also talk about the islet cell tumors, such as insulinomas, and also immune hypoglycemia. And the last one we said non-pancreatic neoplasms, such as fibrosarcoma and hemangiopericitomas. Is that clear?
Yes.
Is that clear to you? All right, let's move ahead. Yes.
So the cause of hypoglycemia, how about general causes such as starvation?
General causes such as starvation.
But those are for only for diabetes.
So non-diabetic, it's possible, in a way, it's possible. I mean, it's possible, but again, in a healthy human being, okay, for the starvation, it means that they can be able to thrive through for some time, because if there's no glucose, as you rightly say, there's going to be what? A positive feedback effect for the release of counter-regulatory hormones such as cortisol, glucagon, epinephrine, growth hormones, right? So these hormones would ensure that what? Gluconeogenesis, glycogenolysis, and even proteolysis and lipolysis have become the order of the day, so that the cells can get glucose for what? ATP production. So it will take some time for them to really experience what? The hypoglycemia. But it can be a cause, generally, yes.
Okay, so Doc, how about the contribution of some other causes such as malaria caused by Plasmodium falciparum, maybe fibroids?
Well, you have a point. You have a point. You know, unfortunately, we cannot cluster all those in here. We are looking at the populous causes. If you are looking at the incidence, by what percentage? Are you getting that? By what percentage will malaria cause hypoglycemia? It can cause, but by what percentage? Then again, that is if it's complicated. Because if you have uncomplicated malaria, it will not give you hypoglycemia. It becomes complicated. One of the complications of malaria is hypoglycemia. Then again, if you look at uterine fibroids, by what percentage would they cause what? The hypo. That is even why we said insulin-like growth factors. Because the fibroids will depend on insulin-like growth factor for what? Glucose to enter into these cells for them to undergo proliferation. You get the point? All right.